evening and welcome to tonight's talk, COVID-19, the short and long-term impact on the Black community in America. This program is brought to you by the Friends of the James Brown African American Room and the Newark Public Library. Please accept our heartfelt condolences if you've experienced loss during this season. My name is Dale Colston, and I'm the principal librarian at the James Brown African American Room of the Newark Public Library. Our co-host this evening is Linda McDonald Carter, a founding member of the Friends of the James Brown African American Room. She's an attorney and a professor at Essex County College as well. With us too are my colleagues Reggie Blanding, who is also a librarian at the James Brown African American Room, and Beth Zach Cohen, a librarian in our New Jersey Information Center. The space, the James Brown African American Room, was named in honor of the late James Library Brown, who was a poet, activist, and influencer who was instrumental in making sure that the library seek and maintain books and resources and present programs examining and celebrating the African American experience. I would like to acknowledge the traditional, ancestral, unceded territory of the Lenni Lenape First Nations on which we are learning, working, and organizing today. We acknowledge that nation and their ancestors. We also acknowledge the devastation and continued legacy of the transatlantic slave trade. Before Linda introduces our esteemed panelists for the evening, may I kindly remind you, if you have not done so already, to please fill out your census form today. We fully understand that many of us have been overwhelmed and preoccupied, but your response is needed. We need to be counted because representation matters. Emergencies like the COVID-19 pandemic are precisely why the government needs accurate census data. Public health experts, government officials, and first responders all rely on population data to make critical decisions in crises like the one we are currently experiencing. Census results affect our community every day. So please visit my2020census.gov to fill out the census online. It takes about 10 minutes. Again, representation matters. And now on to Linda, who will introduce our guests.
Okay, thank you very much, Dale. First, I want to start with Dr. Donald Moore, who earned his MD and MPH in hospital administration from the Yale School of Medicine. He subsequently completed a 3-year surgical residency at Mount Sinai Medical Center. He became board certified in emergency medicine in 1994 and opened a full-time general medicine primary care practice at Grand Army Plaza in Brooklyn. He's currently assistant professor at, I believe it's Will Medical College of Cornell University and Downstate Medical Center. He's at the forefront of educating tomorrow's physicians, scientists, advancing medicine through scientific discovery and improving health. Dr. Moore's vision is a healthcare delivery system that maintains the true essence of the doctor-patient relationship, and his mission is to halt the corporate practice of medicine. Dr. Blackstock, a 2005 graduate of Harvard Medical School, completed her emergency medicine residency at SUNY Downstate Kings County Hospital Center. During her clinical practice, Dr. Blackstock witnessed the impact of health inequity and healthcare disparities on our marginalized populations and communities. She was moved to create advancing health equity with the goal of partnering with healthcare organizations to address a few of the critical factors that contribute to health inequity through speaking engagements, workshops, and consulting services. She's the daughter of a doctor, used her mother's legacy to inspire her to address the detrimental effects of structural racism on health outcomes. Please join us in welcoming Dr. Blackstock and Dr. Moore.
Thank you.
Thank you both. Thank you. So if you would like to begin with maybe some opening statements, then we'd just like to maybe start at the beginning with what is COVID, what is novel coronavirus, what is coronavirus, and all things that are different. So if you'd like to maybe just open up with how this has affected you thus far.
Okay, I'll start. So I left academic medicine in December after 10 years at NYU School of Medicine to focus on my organization, Advancing Health Equity. So these were issues that, racialized health disparities and racial health inequities were issues that have always been dear to my heart and what I've wanted to put my energies into. And I recognized that last year I wanted to sort of to do it in my own authentic way and to partner with healthcare organizations to do the work more so from an external angle perspective than within the institution. And so it was interesting because I left emergency medicine to then just work part-time in urgent care. And urgent care, usually we see very minor complaints like, sore throat or someone has a cut on their hand. But I made this transition during a pandemic, and I ended up actually seeing very sick patients. And so I worked for an urgent care organization at several sites in central Brooklyn. And while before the pandemic, we've had a very racially and socioeconomically diverse patient population, it was only with mid-March I noticed, and our staff noticed, that it quickly shifted to mostly Black patients, Latino patients. Many of them were essential workers or service workers that were coming in with coronavirus symptoms. And initially, when I noticed that, I asked the staff, I said, do you notice it too? And they did. And it's interesting because even at the end of March, I had written an op-ed for Scientific American about why I thought that Black communities in particular were going to be impacted by COVID-19. And I know we'll talk about that a little bit more later, but my worst fears have been borne out. And so as the data is, is being released, as we see more of the data out of New York City and out of major metropolitan areas, and especially in the South, we see, our communities being absolutely devastated. And so, I guess, during the session today, we can talk about, some potential solutions to that. But what's clear is that we are going to be in this for a while. We're going to be in this until we get a vaccine. And so we really need to start thinking about strategies to mitigate the coronavirus's effect and impact on Black communities in particular. Thank you.
Well, first of all, let me just say how wonderful it is to sit next to Uche, next virtually, and to be able to talk about medicine. Medicine is always my favorite subject. It's probably too often it is my only subject. We're at different points in our career, but I see her doing almost exactly the same thing that I did. When I started out, yes, I was going to be a surgeon. See, I'm even wearing the surgeon's shirt kind of stuff. And it didn't work that way. I became an emergency medicine physician, and it still didn't work that way. But I got closer and closer to the patient as I got to what I do now, which is primary care. Over the past 35 years or so, I've had real one-to-one relationship with individuals and relationship with families. And the amazing thing is, I am a student of history as I get older and older. I haven't lived the history, I read the history. I guess I'm getting to the age now where history probably starts when I was born, So the point is, I always look back 100 years ago to that 1918 epidemic as a really changing moment in medicine. Certainly it was where medicine started in America. Many people are not aware that 100 years ago, there really was very little medicine. America was not considered a place where medicine was respected. It was sort of a free-for-all thing. Doctors were poorly trained. If one wanted to be a real good doctor, one had to go to Europe and other places in the world to train to become good doctors. Well, just around that epidemic, 1918, was when science changed in America. And for that next 100 years, we see where things have moved by leaps and bounds to putting America at the forefront of medicine. Well, things seem to go in 100-year cycles. The epidemic did, and now what we're seeing is that medicine is also changing. I spent the last part of the last 100 years learning what I consider to be really good medicine. I went to a great institution. I studied my residency in great institutions, and I studied in probably one of the best places to practice medicine in the world, which is Brooklyn. I think I learned a lot, but I was always waiting for that moment that was going to change what I did, because I saw what I did was not always the best. The outcome of the people that I treated was not always the best. The institutions where I worked were not always the best funded. They were underfunded. And we know about the disparities. You've heard about the 2003 study by the NIH, which basically pointed out that there is unequal treatment, and unequal treatment leads to unequal outcome. And so we see at this point that this is an opportunity to have major disruption. First, we're going to put the fire out. We're going to save lives. Not to say that we're going to change the outcome. This is an epidemic. It's a virus. It comes. It makes people sick. It takes some lives, and then it goes away. So we can do all this stuff. We can throw drugs that we know very little about. We can talk about vaccines that won't get here in time. And we can talk about all these things, but good, solid public health is all we can do during an epidemic. So now we're going to come out of the epidemic, and many of us are still going to be here. What do we do then? Well, what we do then is look back and say, gee, why did we get hit so hard? Those folks over in China, they only lost, they're not only, but they lost a fraction of the amount of people that we lost. They were affected in a way so much less than we've been affected. But they have the greatest medicine in the world. Really? Really the greatest medicine, where most of the people who have been affected by this epidemic are no longer going to even have insurance to pay for the care that they got or the care that they didn't get because their insurance was tied to their jobs and now they've lost their jobs. So it's going to make us think about the kind of medicine that we have in America, the kind of outcomes that we're getting. We get poor outcomes, and I'm sure you all know that. The outcomes are very poor, and for reason. Now, not everybody gets the same level of care. So that's what we're really talking about, a disparity. So COVID-19 has left us with a disparity of the people who got the disease. It's leaving us with a disparity of the people who die from the disease. And it's going to leave us with a disparity of what occurs after the disease. Mm-hmm. But in times of disruption, we can make major change. And that's what I'm hoping is going to happen.
Mm-hmm. Yeah. At the beginning for, I guess, for many of us, it was like February, March, there were maybe 3 or 4 symptoms that we were supposed to look out for: dry cough, fever, fatigue, shortness of breath. What are the symptoms now in May, and are symptoms different for people of color?
That's a good question. I think that in terms of patients that I've been seeing, I've seen a decrease, thankfully, in the New York City area of patients that are coming in with COVID-19 symptoms. I'm actually seeing now people who are on the tail end of their courses. And what's really clear is that it is definitely a fluctuating course. A lot of people will complain of fatigue and shortness of breath. Chest tightness is common. Some may or may not have fever. Some may just have a mild cough. And also, right now we're also in allergy season, right? Yeah. And so a lot of times people are coming in complaining of runny nose, itchy eyes, sniffling. They're having postnasal drip, so dripping in the back of their throat, which is leading to a cough. And so you really have to try to take a good history, do a good physical exam on the patient so that you can understand and be able to differentiate the two processes. But also what's clear to me is that, coronavirus it's a novel virus, it's new, we're learning about it. I think in some people, they're gonna have long-term effects, like, it does contribute to significant lung injury. The people may be having prolonged coughing, may have decreased respiratory reserve, so maybe easily get short of breath. And so that's what we're seeing, especially in people who have had underlying medical problems.
We hear that certain drugs might have a positive effect on some people. Do you envision a cure, or is that possible even? Or is it just going to be management? And either Dr. Moore or Dr. Blackstock?
Yeah, I'll take a stab at that one.
Okay.
Again, years and years of practice, years and years of studying history, we're not going to have a cure for the coronavirus because we don't have a cure for the common cold.
Right.
We don't have a cure for influenza. We have treatments, we can mitigate the effects, we can shorten the duration, and even when we come up with a vaccine, that vaccine, we don't know how effective it's going to be. What do you think the influenza vaccine, how effective you think that is? Of course, I recommend it, and we all recommend it because it's better to reduce a disease by 40%, 60%, which is what we get from the influenza vaccine. But we know that every few years, and there is a new influenza that comes up where we don't have the vaccine. And back in 1918, we had one that was even worse than this epidemic. So the reality is that's just the nature of epidemics, the nature of medicine. It's nice to have hope, but at this point, I don't even have to tell you, forget about the hope, because many people have already died. The epidemic has already, taken its toll. So drugs to use, yes, it's always that way. Whenever we get a major the epidemic or a disease that we are not sure how to treat, we throw whatever we have at it, including chicken soup and
garlic.
Garlic. So please throw whatever you think is going to work and whatever you think is going to make you feel better. But I won't say that that doctor that gets up on television and tells us to take this particular drug. I obviously he needs to go to medical school.
Dawn, if you don't mind, can I piggyback on that?
Sure, please.
For both doctors, it was a tradition when we had really strong consumer laws that it would take 20 years for something to be perfected before it is unleashed on the American public. It appears that in this rush to get it out, that we may end up being guinea pigs. So can you speak to that?
I can take the first stab at that one. And I like your question because your question is a leading one and it gets to the heart of what I just said. Yes, first do no harm. First do no harm. And, chicken soup is not likely to hurt you, but powerful drugs which are going to change the body. That's the definition of a drug. You're going to change the way the body normally operates without proof that it's going to actually treat the disease that you have. Even in that 1918 epidemic, people were talking about bleeding. Hey, let's get back to the bleeding and the purging, that type of thing. Well, I think if we allow our emotions to take over, and then that's the effect that we're going to get. You're right. It takes that long to figure out if a drug works. You can't figure out if a drug works in an epidemic. You don't have the time to develop the clinical trials, the blinded studies, and then evaluate them and then verify them. Because the first time you do a good trial, you may still get a false result. So your answer is absolutely, your question is absolutely on point.
And can I just piggyback off of that? And I would say, even thinking about a vaccine, I know I have heard a lot of concerns from patients and people from our communities about whether a vaccine is something that would be able to be trusted, because what we're seeing is that most likely a vaccine it's going to be fast tracked. Like, there are different phases that vaccine trials are supposed to take, and now these different phases are occurring at the same time, and so we're trying to figure out, is this vaccine going to be safe or not? First it has to be tested, in animals, then in humans, and this is all occurring at the same time because they're trying to get the vaccine out as soon as possible. And so, I think that these are concerns in our community because, we think about the history of the healthcare system as it relates to Black communities, and thinking about how the system has historically and even in current day neglected us and exploited us. So thinking about the Tuskegee experiment, and that was an experiment that was sponsored by the federal government, right? Where Black men with syphilis were told they had bad blood, informed consent was not obtained, and even once there was a cure, penicillin, these men were not given it, and their partners ended up contracting syphilis, as did some of the babies contracted congenital syphilis. And so, and there are other occurrences as well, Henrietta Lacks, it's just to say that, his history has shown that, there is, a trend in this healthcare system not, exploiting our communities. And so when our patients ask about, is a vaccine going to be helpful, or are we going to be guinea pigs? That's a valid question, I think.
Mm-hmm. Dale, I'm switching it back to you.
Okay. Last month, Global Citizen and the World Health Organization presented a TV special called At Home Together, where celebrities and musicians offered hope and encouragement. Abby, a little Muppet from Sesame Street, said that many of us are having big feelings now. It was directed toward children, but many of us are having big feelings now. How can we acknowledge and address the psychological needs of children and young people, and even those in our age group, my age group? Either doctor can weigh in on that.
Okay, I'll go. So no, that is another very genuine concern. I have to even share my own personal story. At the apex of the cases here in New York City, I was doing very long shifts, about 12-hour shifts. One shift I saw 84 patients, but around that time, I started developing chest discomfort. And I'm someone who is typically very, very healthy. And, I have to admit, I was very stressed. I wasn't sleeping well. And so I finally had a telehealth appointment with my primary care physician. And it turns out I had, acid reflux, and I had some gastritis, inflammation of the stomach, because I was internalizing all of this stress. And so, it's real. And even for someone who provides care to other people, we feel that stress too. It's the first time that I've been scared to go to work. Dr. Moore, I don't know how you feel, but even though we have personal protective equipment, I still am scared of getting sick. I'm scared of bringing it home to my family. And I've never felt that way in practicing for over 10 years. I've never felt scared to go to work. And so when I talk to my patients, they have real fears as well. And so I think that having a discussion about the emotional and psychological impact of the pandemic on our communities is such an important talk to have, because it's real, and especially given that our communities are being disproportionately impacted, that these are the conversations that we absolutely need to have.
Mm-hmm. Mm-hmm.
Yeah, in parentheses, you said, and even though we have personal protective equipment, we don't. And
right.
We hear it from the health professionals. I've seen pictures, photographs of physicians in other countries. I won't even mention the name
right.
of the countries.
Right.
They are covered up.
Covered.
Yes.
When we are not. We were. First of all, you heard the difficulty. I go into the hospital, and I had difficulty getting enough of my body covered up. I could not get a hat on the floor to cover my hair. I could, you know, I had to go to a specific spot and get a mask. They don't figure, well, how long is this mask gonna last? They just said, okay,
Right.
you made a fuss, we'll give you a mask. Nothing is covering the lower part of my body. You know, so we did not do a good job, and we're still not doing a good job. So I just wanted to throw that in there for all those people that are shouting, hey, you know, you're not covering us up enough. You're
Right.
not covering us up enough. You're not covering us. You're not even covering us with insurance. Get back to that.
Yeah, and even I want to talk a little bit, even some of my patients who are essential workers who work, you know, in transit or are bus drivers, you know, some of them have told me that they were so scared to go to work. Some even said, I went out on sick leave because I was scared to go to work because I was not being adequately protected. We weren't even given a mask. And one even told me who works for transit that they were explicitly told by their supervisor not to wear a mask at the beginning of everything because it would scare the passengers. And so, you know, of course, a significant number of MTA employees I've actually gotten sick as a result. Yes. Yeah, because they're exposed to the public, they're exposed to sick coworkers, and they look like you and me.
Yes. Yeah. Linda, do you have another question? We have quite a few in the chat room. You'll ask a question and we'll take some of the questions from the participants.
Yeah, I'm going to make this quick. Dr. Moore in particular. Well, for both of you, it appears that you agree that the experience that Black people are having now in America with regard to the pandemic is part of the ongoing historical plight of Black people in America anyway. Having said that, I know that Dr. Moore has a special thing in his heart for this issue of insurance, because that's the issue for our community. So if you could speak to the whole matter of insurance and coverage, especially since we have record numbers of people in America, that, you know, in addition to Black people, we have record numbers that are comparable to the Great Depression of people who no longer have insurance with their employers. Can you speak to that, Dr. Moore?
Sure. I'll start off by saying that nobody in America has good insurance, right? Because the insurance we have is not comprehensive. And as a result of it, our population as a whole does worse than most developed countries in the rest of the world. So we start there where you're under insuring or not insuring a significant part of the population. And then the method of insurance is a problem. For example, we get our insurance from our employer. That's a large percentage, unless you're over 65 like me and you get it from the government after we paid them for our work life, right? And if you're a baby, you get it from your parents who are working. So the substantial majority of the population is insured through their employer. But guess what happened? We just got hit with a tsunami and all these people lost their jobs, right? Millions and millions. Some 30 million people are filing for unemployment, losing their jobs, right? What do you think happens to their insurance? Oh, they lost it because they're not employed. So you can get COBRA, of course. COBRA is that insurance that you can go and buy it from the insurance company after you've lost your job. But wait a minute, buy it with what? You have no income, you just lost your job. So we don't have insurance. And then we go to the hospital because we are sick. Maybe we had the virus, or maybe we thought we had the virus. Well, do you know they expect you to pay a large portion of that bill, even though you have insurance, but you still have no job? So the fact is, we're going to hurt. We got hurt by the virus, and now we're going to be hurt by our healthcare system, who is going to take food out of our mouths, roof from over our head, in order to give back to the hospitals that we really need. We need those hospitals. We saw how much we needed them, right? When we really get sick. So we need that. We need the health providers. How are we going to pay them without insurance? You can't pay for this stuff out of your pocket. And of course, the prices that we charge are just, they don't make any sense. So our healthcare system needs reform. And as I said, during disruption, you have an opportunity. One of the things that the 2003 Institute of Medicine pointed out, that we have a very fractionated healthcare system, and if you divide how you take care of people by their income and their insurance, you're not gonna do an effective job. You're gonna create disparities, because if you're giving the frontline worker lousy insurance, when that frontline worker is at higher risk, when they get sick, they're gonna get lousy care because of the lousy underfunded institutions they have to go to.
Yes.
So, you know, it all tumbles over and over and over. So this is disruption. We have an opportunity. Let's reform our insurance. Let's not reform our insurance system. Let's have a revolution. Let's throw out this employer-sponsored insurance and let's move to a single-payer insurance. We've figured it out. We have the JBAAR bill in the House, and we have the Saunders bill in the Senate. We have a bill in New York. If we want to do it state by state, we have it's all been figured out. We just now have to have the will and the desire to change it.
Just two quick things, and I know we have a lot of people who are chatting in. One is, do you anticipate more pandemics due to globalization, environmental disruption, the deregulations, and how should Black people, or how should the country prepare, but particularly our community, because we're getting hurt so bad? And what role can the community elders play that will best serve the community? For example, the knowledge they have of traditional remedies that have been proven effective over the last 100 years or so since chattel slavery. And what can we do to prevent or lessen the exposure to the virus? So I know I put a lot in there, but I've heard you answer this before. So I'd like to hear from both of you, and then we'll go to the audience if that's okay with Dale.
Yeah, sure.
Well, that's a lot. I think I may have to be reminded about what was said. So, oh no, absolutely. I think we're going to see more pandemics because of globalization. So it's interesting because I think when we first heard about coronavirus in late 2019, I'm sure many people thought, oh, that's in Wuhan province in China, and that's nothing to do with me. And literally fast forward,
Yes.
2-3 months, and it's devastating. The world and our country and our communities. I definitely think that climate change is going to be a huge issue that we need to really think about, especially in terms of pandemics. And then just in terms of what our community, was the question what our communities can do? Was that what you're asking?
Well, the first, before you end, with regard to deregulation, because a lot of things are being deregulated, and then it was how our community can anticipate, get prepared for what might be coming down the line in a couple of months. Go ahead. Yeah, no, I mean, I think, we are in the middle of it. And so, what's interesting is that we're getting all this data that's coming out from, CDC about, our communities being disproportionately impacted. We have the highest tested, we're being tested, we have the highest cases and mortality rates. But I think we need to start thinking about solutions to this. And so I think actually one of the solutions is that we need to target Black communities equitably. So, if you're thinking about which communities need the most widespread testing, it's our communities. Which communities need contact tracing, it's our communities. And I think that's only going to be done through community-based organizations, like working with faith-based organizations, neighborhood coalitions, using community health workers, really being innovative and thinking about how we can do outreach and education in our communities. It's interesting because Anthony Fauci, when he, at his press conference, I think on April 7th, when he first mentioned these racialized health disparities that we were seeing, he said, oh, we're gonna have to deal with this, afterwards. Well, no, we have to actually deal with it now because we're gonna be in this for a while. We have to think about solutions and to mitigating the virus's spread and devastation on our communities too. I just heard a woman who, I think she wrote for the New York Times, a science reporter, who conservatively said, we're going to be in this conservatively for the next 36 months. Anybody want to comment?
Yes, I can comment on that last point and go back to, strategies on how not to be caught with our pants down again the next pandemic. They always come, right? They have always come. We've always had plagues. A virus doesn't come, peaks, and then goes away. You know, it's a virus. It's going to be, right now it's at an epidemic proportions, but it will become endemic. Endemic means you're embedded in the society. People have it. It's at a low level. It hurts people still. It causes deaths still, but it is still with us. Now, so yes, the answer is, of course it's going to be here. And of course we would like to have a vaccine so we can deal with it and prevent it and keep it suppressed. And so that suppression phase of the epidemic, that's where we're going to go after we've had this big curve and this big devastation. So sometimes when you're in a situation, you believe that this is the only way it can be, and we're doing our best, and listen, we have the best here. There is nothing else. Well, that's not the case. This pandemic did not affect all countries the same. Why did the people in South Korea not have the kind of rates that we have of new cases, deaths, and all the problems? Why did the people in China not have the same issue? Because they were prepared. Why were they prepared? Because they've had this before. What happened is in 2003, they had a coronavirus issue. And back again in 2013 or so, they had another one, and they got criticized. People looked and said, well, gee, we didn't handle this so well. We won't get caught like this before. So let's figure out how to get our emergency preparedness in order. What did we do in this country? For the last, I guess it's how many years that we've had this change in administration, we stripped away all our public health protections. We took away our public health protections. If you remove all the things that are there to protect you, when the problem shows up, you'll be unprotected. We got rid of our stockpile of masks. We got rid of our stockpile of all the things that we needed. And all of a sudden we said, now, oh yeah, no problem, it's not gonna come. Well, it will come. And so it was our emergency preparedness that left us in this state. Of course, there are other issues. We know that viruses change. Maybe the virus changed as it jumped from one continent to the other. I have no doubt that that is a factor. But it's really hard for me to understand why one country, two countries on one side of the world did so well and countries on the other side of the world did so poorly, especially when we have so much resources.
Mm-hmm. Well, Del?
Sure. I think the doctors touched on the possibility of a virus coming this fall. So we'll move on to the next question.
Oh no, but I do want to just mention the concern about the virus this fall is that it's still going to be around, but also this time it's going to be around during the flu season as well. So that's also the concern, that people will have both flu and coronavirus and do very, very poorly because of that.
And if I just may add a public health point here, epidemics sort of have waves. You know, the first one could be the big one, or the second one could be the bigger one. In the 1918 epidemic, we had a spring wave, which was it was a very virulent virus, but it wasn't as big. And then it came back in the summer. Believe it or not, you know, this virus was there in the summer, and it really peaked in the summer, and then it came back the next year, you know. And so yes, we can have those waves, and we may have these waves. This is novel. We've never seen it before, so we don't know how it's going to go.
Yeah.
Okay, Del.
Oh, thank you both. The question is, does the medical community believe that a person who has survived the COVID virus has an immunity to that disease?
So again, it's a novel virus. There's so much that we don't know. So the different types of testing that's out now, and one test that is being offered is the antibody test. And I think a lot of people probably have questions about that. So a lot of these antibody tests, they test to see whether you have developed an antibody in response to being exposed to coronavirus. And so what is interesting and very important to point out is that while, say you test positive, meaning you have the antibody and you may have been exposed, we don't know whether that's full immunity or partial immunity. We also don't know how long that immunity lasts. Is it 10 months? Is it 12 months? Is it a year or 2 years? Again, it's a novel virus, and that all remains to be seen. So, you know, I often get a lot of patients asking me questions about the antibody testing and are they safe if they test positive? And we really can't say for sure.
I agree.
Okay. Another question, is the COVID virus blowing in the wind? Can it be transmitted by animals like bats and birds?
Well, it is blowing in the wind. How far it goes, we don't know exactly, but we've got so many models that show us that. We know that TB floats around in a room and just goes around and round and round. Probably this one doesn't do it to the same extent. When you get an infection from any organism, your dose matters, the amount you get. If I come up and cough in your face, I've given you a big, hefty dose. That's why we should wear masks. But we know that virus penetrates the regular mask. Maybe the more sophisticated mask, like the N95, it may have more difficulty penetrating. But then, you know, if you walk around and touch a surface and then adjust your mask because it doesn't feel right, you just brought the virus all the way to your nose. So yes, it does float in the air. That's one method of transmission. You know, then we have the direct blast from a cough or a sneeze. That's another mode of transmission. And then, of course, we have the contact where we're taking it and touching our faces. So yes, there should be concern about the virus floating in the air. But if you go to the park and you're in a big open space and the wind is blowing, you're probably okay. So it's a good thing to go to the park, build your immune system so that you can fight the virus if you do get it.
Agreed. And can I just make a point that, you know, the idea of everyone wearing masks. So, you know, in the New York City area, you know, what we advise, everyone should wear a mask when you're outside and you're within 6 feet of another person. It's really to prevent someone who is infected from infecting somebody else, because what we're, you know, they're advising you can even wear cloth masks. And so that's actually more effective from a sick person passing on the virus to someone else rather than being protective for a non-sick person that's wearing it. So I just want to make sure people understand what that's about. But if everyone is wearing masks, it actually is protective for everybody.
And if I may jump back in again about, you know, we were talking about, you know, I was talking about why one population got the disease so much and another one didn't. Do you remember what we thought of masks at the onset of this epidemic? You know, we weren't wearing them. We were looking at people over there and saying, look at those people, they're always wearing them. We were making fun of them. We had people around here talking about, well, it's not going to get here, it's a China virus, and so on. So it was our attitude that hurt us in the long run. We didn't get started until the disease was already widespread and all over the place. Now we want to test everybody and contact with them after everybody already had the disease. You know, you're kind of coming late, too late.
Yeah, I know.
You sort of touched on the next question. What do you believe needs to happen before we reopen the economy? We know that some of the southern states have already reopened, and I don't know how well that's working out for them, but I guess this refers to the New York, New Jersey area. What do we need to do before we actually reopen?
Well, you'll probably be surprised by my statement on this question. We do need to reopen. You know, we are afraid, I'm afraid, we're all are afraid. But the solution, we can't stay in forever. We're gonna have to change our behavior. You know, packing patients in a doctor's office, chair next to chair next to chair, like they're on a subway thing, was never a good idea. Doctors were doing the wrong thing. The way we construct our offices are wrong. So we need to change our behavior, not just for this epidemic, but moving forward. When you go to a doctor's, doctors should not have waiting rooms filled with
True.
patients coughing on each other. Those are sick people you're packing together.
Yes.
Okay,
Yes.
so we don't know how much, we didn't have an epidemic then, so we weren't counting how much disease we were spreading in our offices. We shouldn't be seeing 80 patients a day. We should only see 5 or 10 because that's the only amount we can see correctly. So we need to change all of that. If we had good insurance and we paid the appropriate amount for the visit, and each person wouldn't have to go to 10 doctors in a month or just keep running from doctor to the doctor so the doctor can see you for 2 minutes. Let me stop. I shouldn't speak like that against my colleagues, but we are doing it wrong. Our systems are wrong, and we're doing it wrong. We need to change all of these things. Anyone who has heard me, have heard me say all these things already. So I guess you can't throw me in jail at this point.
Oh yeah, but can I say one thing?
Yes,
Can I say
yes.
another thing? I agree with Dr. Moore that, we're going to have to get used to this new, not even new normal, new abnormal. But I also think that one of my concerns with the reopening, and yes, definitely needs to happen at some point, that there are markers and indicators that, public health experts use, like, you should be seeing a decrease in cases, over a 2-week period. And there definitely are some states that are having partial or full reopenings, and they're still going up, so that's concern. But my other concern is that reopening will is more likely to expose our communities, Black communities, to the virus, because, we're the ones who actually really need to go back to work, right? And so that's just my concern, that when it's done, that it's done in a way that, we're making sure that people are protected, when they're at work.
Here's another question in the chat room, and this is about children. Do either of you have any information regarding the impact of inflammatory syndrome that we're hearing about children being affected maybe in the last week or so? That's a concern for parents, surely.
Yeah, I know. I just read about it in the New York Times yesterday. I was talking to my husband about it this morning, and I got the alert from the New York State Department of Health. It sounds like there are very few cases, but obviously it sounds very concerning. It sounds like some of the cases, the children did test positive for COVID-19, but other cases, children didn't. So I think we're still getting a lot more information about it. I know it's, definitely disturbing to hear it, because the information that we had so far were that children would be, have very mild symptoms, if any symptoms, with this type of coronavirus. And so I think it's definitely something we need to get more information on.
I just wanted to ask a quick question.
Oh, go ahead, Linda. Yes.
Yeah, about, either one we can comment, but how do we prepare our immune systems to the extent we can for those of us who are privileged enough to do some things to help? What would be your recommendations for enhancing your immune system? Because we do have a sizable population of people who are Social Security age. And what can we do in terms of preparation? And that's something I want you to speak to in terms of building immune systems.
So I like that question. Now, if you are immune deficient because you're on the medical treatment, then you should be in a bubble. And that's not just said in jest. You should be in a bubble because we have unnaturally impaired your immune system for medical treatment. But as Homo sapiens, people who are walking all over the earth, we should be walking all over the earth. We should be exercising. We should do, I'll tell you what I personally did. When I saw the epidemic coming and I was slackening up on my exercise, I said, I better get back to my exercise routine, because if I get hit with that, I want to be at the peak of my game. So I started exercising further, back to what I used to do. And you know what? I stopped the junk food. I started buying good, healthy, wholesome foods, and you know what they are. So that's what you do. That's how you build your immune system. We know that exercise builds your immune system. So again, if you like chicken soup, you take that. That would do it. If you like to take supplements, you take it. But what's proven in pretty much all our endemic diseases, when we have had epidemics, is those who are best, who are healthiest at the start, and who are doing things that are healthy for human beings are going to do better than those who have impaired systems because of either poor lifestyle or just being unfortunate.
Yeah, my colleague, sure, go ahead, doctor. No, please.
Oh, no, I did want to just say to that is that, so one of the reasons that we know that the coronavirus is impacting our community so much is because of the higher chronic disease burden that we carry, diabetes, high blood pressure, asthma, obesity. And I want to say that, we talk about the social determinants of health, right? We talk about, access to, housing and employment and quality education and not just access to healthcare, but quality healthcare, right? It's all factors in someone's health. But we also know that structural racism is a driving force of that. So I will say that I think that, yes, definitely there are individual things that we can do, but I will say I feel like racism has left our communities sick, right?
Yes.
And so while and not to disempower us by any means, but yes, I think that we should do all that we can individually, as Dr. Moore was saying, like try to eat the healthy diet, and also one other thing I hear from a lot of my patients, my Caribbean patients, they have been taking garlic and a lot of different herbs, and some of my Chinese patients are taking traditional medicines, and what I tell them, keep doing that, because we don't really have any evidence that any of this other stuff, hydrochloroquine and remdesivir and other medications, we don't have any evidence that those are effective. So keep doing what you're doing, but also,
Yes.
Good hand washing and physical distancing and all of that as well.
Mm-hmm. Thank you.
I just say I find it interesting
Mm-hmm.
that people are getting back to washing their hands when that's what people did normally as part of home training, washing your hands. So this is really interesting for me.
I know.
Oh, one quick question. If they open all the windows in their house, right, do they still have to wear a mask?
You mean
If they
wear a
open all
mask
the
at
windows
home?
in their house, if they open all their windows to get fresh air, should they have a mask on?
I like that question because I've always believed in opening windows. I believe these structures we build these days that have all this this glass that allows you to see out, that makes you feel like you're out there, but you can't open a window.
Okay.
Yes.
That is not good construction, because what's going to happen is all that stuff that's in that building. You saw what happened on 9/11 when that building crumbled, how people got sick. So it told you that what we took to make the building can make us sick if we crumple it up.
Mm.
Well, if you lock the building up and lock the people up in the building, that stuff is going to seep out. So this is a big planet. We have lots of fresh air if we just open the window. That's why I like parks, and I say keep going to the park. And I'm glad that our governor and our mayor have kept the parks open. So if you're in your house and you open the windows, yes, air from outside is going to come in, but that air is going to be actually more pure than the air that's inside your house. So you don't need to put on a mask because you've opened your window. You put the mask on, as Dr. Blackstock pointed out, to prevent your effluent, your stuff, going and infecting other people. That's why you're wearing the mask. You don't need the mask in your house.
Mm-hmm.
Okay, Joe.
Thank you.
Unless you're taking care of somebody in your house who has the virus.
Right.
Mm-hmm. Yeah. I think we're coming to the end of our hour, and we want to give Dr. Blackstock and Dr. Moore an opportunity for some closing comments and perhaps recommendations for us all. Dr. Blackstock?
Oh, well, first of all, I'd like to say thank you so much for having me. And it was an honor also to be a guest along with Dr. Moore, who I've known since I was a little girl. Not to age you, Dr. Moore.
No, that's quite fine.
but I wanted to say, we're definitely, we're in this unprecedented time. It hurts my heart how much this pandemic is influencing our communities, but I do see some light, and I'm actually very inspired with what Dr. Moore said, that in times of crisis, that it's time to disrupt the system. And so I'm hoping that people who care about health equity and care about our communities can really get together to affect some change so that this doesn't happen again, at least not to this degree.
Mm-hmm. Thank you.
And,
thank you. Yes.
Again, the pleasure is all mine. Blackstock comes from good stock. You know, I had the opportunity of working with her.
You're still there.
You're still
I'm still
there?
there. So anyway, I had the opportunity of working with her mother many years ago, and Dale was really an inspiring physician, and I think to inspire two children, twins, to become doctors is a great thing. So that part is great. And Dale represents a new generation, a different generation. And I think medicine is something of a legacy that we need to continue to, to bring forward. So I also want to just again reiterate the point that epidemics are going to come and go. What does not come and go is our societal structures. I'm working right now in Brooklyn to bolster the infrastructure there. We have a great university hospital in Brooklyn. We have a great public health school in Brooklyn. We have a medical school in Brooklyn. And I use Brooklyn as emblematic of the Black community, the minority community, part of the communities that are sort of left behind. Trillions of dollars have been allocated. We want to make sure that those monies go into our structures. When we talk about structural racism, we're not going to correct it by doing something fancy or whatever. We're going to do the same thing everybody's doing it. We just have to do it more equitably. We're not going to give a different medicine to all the Black and brown people because they have a different disease. We're going to give the same good medicine. We're going to practice good medicine. So it's great to have people like Dr. Blackstock, who, when I am no longer around, is going to carry on that type of work and give good medicine to the people.
Indeed. Thank you. Thank you, Dr. Uche Blackstock, who can be found on Twitter at Uche_Blackstock. And thank you, Dr. Donald E. Moore. We appreciate both of you, and we're going to stay in this fight together. Everyone be safe. And on behalf of the Newark Public Library and the Friends of the James Brown African American Room, we thank you and be safe. Good night.
Thank you so much.
Take care. Thank you, guys.
Okay. Thank you.